Everyone. Welcome to today's ASH webinar on the new CQC guidance on smoke-free policies in mental health inpatient services. And the purpose of today's webinar is to give an overview of the updated CQC guidance and the key implications both for CQC inspectors, but also for mental health services. And it's great to see we've got so many people joining already. We've had almost 200 people registering for the webinar. And can I just ask everyone to make sure your mic is turned off and your camera is turned off as well? Teams should be doing that automatically, but sometimes it's a little bit finicky. So please just mute yourself to make sure we don't get background noise. And so ASH was pleased to input into the development of the CQC guidance along with several other organisations. And last year, we held a workshop with mental health professionals to discuss their experience of CQC inspections and the previous CQC guidance on smoke-free policies and reflect on what worked well and what could be improved. And we fed this back to CQC, and I'm very pleased to see that they've taken that feedback on board. I'm looking forward to hearing more from them about the guidance in a couple of minutes. So do you want to put up the agenda, Elliot? So we've got a really brilliant set of speakers who I'm sure will give us plenty of food for thought. So the presentations will cover the kind of CQC perspective on the guidance, perspective from mental health practitioner, and then also some lived experience reflections. So we'll have a good kind of mixture of views to inform the discussion. And then onto the housekeeping slide as well. So this meeting will be recorded and uploaded to the ASH website and shared with all of our networks and all the attendees today. So you'll be able to use it as a resource, share with colleagues in the future, all of that. So please can, as I said before, please can all panelists and attendees keep themselves muted and turn off their videos unless they're presenting. We'll be muting people who have any background noise when they shouldn't. And we encourage all attendees to submit questions and reflections in the meeting chat, which we'll cover in the Q&A session towards the end. And I'm sure people will have suggestions for kind of further changes and additions to the guidance, but I just want to measure people's expectations. This guidance has already gone through a very lengthy consultation process last year and has very recently been updated. So we aren't necessarily here to give CQC a list of further changes to make, although of course people are free to make suggestions. Today we're focusing more on understanding how the guidance has changed and what the implications are for services and smoke-free policies. And if you have any other issues, please post in the meeting chat or email admin@smokefreeaction.org.uk. And if you have any technical issues, I would suggest checking the meeting settings and making sure you have the right audio microphone selected, or just leaving and rejoining, which is usually my first suggestion. So moving right on to our first presentation. So we're going to hear from Paul Bingham, who's a senior specialist in mental health with CQC. And Paul's going to give us an update on the new guidance, a new CQC guidance on smoke-free policies. Paul.
Thank you, John, and welcome everybody. I've done the usual thing where you're working from home and I've had to pause the washing machine so I can hear myself think at the moment. Just to say that, just a very brief background into myself. I am a mental health nurse. I kind of lost my registration after 36 years ago, about 3 years ago, as part of a house move. So my background, as I say, is I think working many years ago from the old asylums where I first started, where smoking was the absolute norm for everybody. And I've been through that journey over many years in various different settings, through learning and development and commissioning through to CQC. And I've been here for approximately 8 years. And we can take you through hopefully what we've done. Next slide, please.
As whole and healthy foods. So I think we have got to.
I think there's some background. Brilliant. I think for the purpose of myself and today, it's hopefully around discussion and being as relaxed as possible in getting the points across. And at the end, there'll be a Q&A. So I've got some background on why we've developed the guidance and some consultation issues and who was involved. I think there's some context around CQC transformation implications, and that's some of the transformation that we've undertaken over the past 2 years, which I think is quite key in terms of how we engage with people. It's putting some changes around the guide that's not just for CQC staff, but I think it's for everyone. You know, it's we have to remember that as CQC staff that we have people who we know people who use services, and we are users of services ourselves. But hopefully it'll be useful for yourself. Next slide, please. So, as John's already said, people who developed the guide, and there was a lot of hard work that went into this. I will say I wasn't part of this process, but I do know that there was a lot of input from the CQC itself, and there was very useful discussions. So certainly there was people who have lived experience of using mental health services. There was clinicians from the independent sector as well as the NHS. There were our own national professional advisors. Certainly ASH were involved, and it's very key. And if we can go back a slide, please. And certainly we've had Department of Health involved as alongside NHSE. So there was a broad range of opinions and people with experience around this field, and not just around smoking, but in general about other areas such as restrictions on people. Next slide, please. I think for us, and hopefully this is true, although certainly there's a challenge sometimes, but CQC does reflect the concerns that wider society have and take opinion around Department of Health, NHSE, those people who develop guidance and research such as NICE, and I think it's really important that we reflect on issues that impact on the health of people who use services. And there's been a lot of work that we've done over the recent years to ensure that people with lived experience have a voice, that carers have a voice, and certainly in the new guide and transformation of what we're trying to do, that if we do any assessments or inspections, you know, part of the quality statements and the way we work have I statements. So it's all about the person at the centre of their lived experience. But we've also seen that the system has been grappling with smoke-free environments over several years in relation to mental health settings. And when we work with people who with lived experience or NHS trusts who oversee high secure hospitals, you know, there's a lot of work that's gone on, people within forensic services. So we absolutely understand and reflect, so we've been grappling, and I think in the development of this guide, it's really important that we get the opinions of everybody, which we have. Next slide, please. I think it's understandable, and it's part of our guidance, and we take a lot of internal advice from our Mental Health Act and mental health policy makers around the work that we do. But it's important to understand that care providers have a duty of care to protect the health and promote healthy behaviour. And we've seen this over the years. I think one of the big reflections for me around mental health is, I suppose, the work that we've done around people's physical health, where many years ago, and I've been around a long time, there was a lot of work that focused just really on diagnosis, illness, treatment, medication. But the work that's been done around people's physical health is really important. We also kind of reflect that providers need to have effective support to stop smoking or temporarily abstain from smoking, and even just promote consideration around smoking in general and the impact that it can have on people's mental health and physical health. We know smoke-free policies, as said, have been seen as contentious, and everybody has to grapple with that. But in response to legal challenges, Court of Appeal has ruled that smoke-free policies do not infringe human rights. So that's a good starting point in terms of us trying to develop this guide. Next slide, please. Right, I think this is really important to get across for people. The development of brief guides, and it's who it's for, but it's out there and it's publicly available. And I think there's a reflection really that we can't be at CQC an expert in all areas, so we develop brief guides for people to follow. So it is that learning resource. So there is good reference, there's links to professional guidance, and this is why it's important that we have this collaboration. But it does not provide guidance, which it says there, to registered persons about complying with the Health and Social Care Act, or they further indications of assessment pursuant to Section 48. Now, it's important to reflect that this is our guide, but we should be open in speaking not just about this guide, but about the guides in other areas to people who use services or people who work within services. Next slide, please. I don't think we can talk about smoke-free environments without talking about blanket restrictions. And I think that, you know, one of the things that we grapple with, or yourselves as providers, but also people who use services, is that sudden change in circumstances that does happen when people's mental health does deteriorate and they may need to come into a hospital, and whether they're informal or people are detained, that change in circumstances changes people, and it can lead to that kind of conflict really around restrictions, because many areas, well, most areas are smoke free anyway, but around blanket restrictions, and there's sometimes a bit of a grey area in discussions that we have with people, is around that restrictions that apply to all people, patients or people in a particular setting, should be avoided. And we try and encourage avoidance of restrictions. But we do understand there will be areas, there will be settings where there's necessary to have restrictions for people's safety and that of others. But any justification or restrictions around this, the guide that we tend to follow is around the mental health, that code of practice. Next slide, please. This is just about the work, why we've changed, and some of you might be a bit more familiar with this than others, and CQ are still working through our transformation. This guide will continue anyway, but it's the way that we work with yourselves moving forward. Now, our previous way of regulating has been in place since 2012, and many of you have been subject to these inspections or joined us on inspection. We have a lot of experts by experience and specialist advisors, and gone are the old school days of where you might get a coach load of inspectors turning up with support, or you might get 8 to 10 people coming on inspection, and that is the only descriptor of the, I suppose, the way that we let people know in the public how good or not a service is doing. We needed to evolve our approach to keep change with a lot of stuff that's going on in terms of wider society, in terms of what's happening across the NHS and the independent sector. And we had to reflect that there's a lot of advances in terms of digital technology. I went back probably about 4 years ago, and I can remember working in an office in Birmingham. There was myself and 2 other colleagues, and we were grappling with well-led inspections and doing all the reports. And chief executive came in and just asked us some questions really, and I think it was fair comment that we were grappling with the technology that we were using. We were working different systems to understand all the information that was coming from people who use services, from providers, and we needed to get ahead of the game and get better technology. but also grappling with the fact that we had so much paperwork that it was really hard to get into sometimes the detail. And all of that went into those very, very large reports. And sometimes we could write a report where we inspected about 10 core services, where we did a well-led inspection, and that report could be 200 to 300 pages long. And then we had to actually think, well, who reads that? So to keep pace and make sure that we get our ratings and assessments right, there's a new approach to what we do. And we've worked across the health and care system with people to kind of get feedback. So any kind of assessment that we do is flexible, it's more timely, and we're working towards that. So we can actually let people who use services or maybe want to understand, you know, where a person might go to a care home if they've developed dementia, you know, they'd have an up-to-date rating or an up-to-date assessment of what that provider's like. So it's important that we keep moving forward with that. Next slide, please. I think there's a clear distinction in new ways of working, the way we're reporting about people who use services will, and it's the I statements and then the providers, and it's like we will. So people who use services, hopefully will have the confidence that we have that up-to-date view of the quality. They'll know how to find information about the quality of care better. There's been significant amount of work going on in the background to ensure that our technology and the way people access our websites, they can understand how we've come to any judgments, but also they can understand and make judgments for themselves to say, yeah, that's a better service for me. Understand about the standards of care that they have a right to expect. And it's not just people, well, it's about all of us. What is our right and what should we expect? And also really play a part that they are active partners in their own care. It's also important to understand, and we've found that there are people who don't feel safe within services. So we've got to improve our systems to understand when people do feel safe and protected, that they have a voice in their care, that I think especially in care homes, residential services, there, as we've said, where is learning disability or autism, and certainly across vulnerable groups like mental health services, that people do feel protected, they do have a voice, and they have progression to move forward. Next slide, please. And for providers, hopefully they have a clear understanding of what our expectations is, and we have to keep working on a positive relationship with providers. And it's important that we share information as possible. I think we've always had this idea that we do need to be proportionate, we do need to be consistent. Sometimes that hasn't always been the case, and providers have come back to us and said, yeah, we need to be a bit more consistent in the way, and we're working towards that. And you need to have confidence in us that, you know, when we do rate and we do update those ratings and their judgments, that's done in a consistent way. We're working across systems now and see how we can work and to improve how providers will work in systems, and feel empowered to set ambitious standards for the safety alongside a learning culture. And it's really important that we understand, that the public understands that we need that learning culture. And even I think that journey around smoke-free policies and smoke-free environments, there's been a massive learning curve, but there's been really good work moving forward. Need to understand how CQC is changing. We'll do a little bit more about that later on. Next slide, please. So the brief guide, some of it covers and the implications. It should be on the website. I know we had some issues last week about uploading it, but I'm assured that it is going on the website. There's covers policy, leadership, supporting people, supporting staff, to all of those areas, and covers areas such as confiscation and destruction of people's smoking materials. that can lead to distress. And it does cover around the community mental health services and deciding which regulation applies. Next slide, please. I think if we just take a few of these here, I think it's important that it's people are at the centre around developing any kind of policy, but also centred around supporting people prior to and during admission. It's important that we all have honest conversations, that people who may live within hospitals or who are supported to give up smoking, that they are at the front of the conversation, that we don't just write a policy without people and staff. There's also stuff around staff, and we found this quite a few times around staff clear about e-cigarettes and the policy. And I've only got a few minutes to go, John, but it's sometimes staff aren't aware or clear about the policy, and then that could lead this could lead to some kind of conflict, and we found that. And it's not just around smoking, but it's also around other blanket restrictions. Next slide, please. I think this is key. There's some considerations in the application around the guide. What we found sometimes is around searching, where quite a while ago within some settings as contraband, we search. Well, you search. We have to understand is an appropriate use of searching around the policy. There's risks about exploitation, that if around banning smoking, it's around how that could be exploited, you know, on mental health wards. Sometimes it's around people just keeping lighters on themselves, and we have to understand in terms of policy and how we manage people because of fire risk. Talked about escalation of distress and people kind of, you know, giving up smoking, because we know it's not easy. So there's a few things around considerations around this application and the way we interpret the brief guide. Next slide, please. I'll do the next slide because of time. So some of the issues around regulations, where we talk about person-centred care, dignity and privacy, safe care and treatment, and around safeguarding from abuse. You know, I think when we talk about these and around blanket restrictions, we have to ensure that people have a say in their own care, that they're supported to have a say moving forward, that any conversations ensure that people's dignity and people's choice are taken into account. We also have to understand the impact on people, you know, around any restrictive practices. Next slide, please. Thank you. I think that's about time. I will say I could talk all day on this, and there's a lot more nuances around the guide, but there's some clear thinking about what we should do. Just a couple of very last things around this is that it is a responsibility of hospital managers. It's a responsibility to make sure that the policy is followed, and there's certain things that the CQC does and doesn't do. For an example, you know, we shouldn't challenge smoke-free policies. Really important around that. We recommend that where on wards are using Section 17 leave, the people that staff and certainly people who use services need to understand that where patients are using Section 17 leave as an example, it's not about taking smoking breaks. It's about people using leave as part of their journey, about people moving forward. We also support a sensible approach of retention of people's smoking materials when we talk about confiscation until the patient's discharge, even though we understand that storage is sometimes quite difficult, and we need to understand and respect the services policy that states smoking materials will be destroyed. I think that's about it, John. All right, thank you.
Thanks so much, Paul. That was a really really comprehensive update. Gave some really useful context around kind of CQC's remit and some of the changes CQC have been through in kind of recent years as well, and that kind of transformation process. So thank you for that. So please do put any questions for Paul in the chat. You know, you've got him here for an hour today, so make use of that, and we'll get to those questions in the Q&A at the end of the session. So next up we have Mary Yates, who's a National Centre for Smoking Cessation and Training consultant and a mental health nurse, who's going to give her reflections on the new CQC guidance and why smoke-free policies are so important for service users in inpatient mental health services. So take it away, Mary. Still, oh, I'm not sure if Mary's still with us actually. Let me just see. Let me just see if I can make her a presenter again. We've had a bit of a technical issue there. Mary, can you?
That's okay. You've just unmuted me. Thank you.
Sorry about that, Mary.
Oh, that's okay. Hello, everyone. Good morning, and lovely to see some very familiar names. Thank you, John, for inviting me, and also Elliot for all the work in the background. Great to be part of this session this morning and to talk about such an important issue. And thank you, Paul, who's spoken about some of the things that I was going to speak about. So I leave more time for you to ask questions. Next slide, please, Elliot. So in the next 10 minutes or so, I'm just going to talk a little bit about why this guidance is needed. And it's really fantastic that it's been updated. Why smoke-free is important and some of the takeaway key messages from this guidance and how we're going to go forward and implement it so that it can help us to improve services for our patients. Next slide, please. So I begin, I think, with the very obvious statement that tobacco dependence is uniquely dangerous. And as Paul said, in the past, my experience as a mental health nurse was that traditionally we all thought that tobacco dependence was a lifestyle choice, or that it was a bad habit, or that it was a personal freedom. But of course, what we know is that it is the leading cause of physical, mental, and social problems, not just in this country, but across the world. And so that is why we now have a new standard of care, a new commitment that all of us, wherever we work, whether we're in acutes, maternity, mental health, learning disability, whatever service we're working in, we must all be on the same page. We must all recognize tobacco dependence for what it is: a preventable illness, a chronic illness, a relapsing illness, but thankfully one that has evidence-based treatments. And that's what we need to embrace and employ on a daily basis, on an hourly basis for all of our service users across our services. And our ambition is that we will be completely smoke-free in this country by 2030. And I'm really excited about that. I can't wait. So, but in between times, we've got some work to do. If we could have the next slide, please, Elliot. I want to highlight the fact that the reason why we have such big inequalities in smoking rates is not because people with mental health problems aren't interested in quitting, not because they haven't got the capacity or the capability to quit, but it's mostly because we have created environments, and Paul told us that, you know, he worked as a mental health nurse, as I did, about 23% of people in the mental health hospital where I worked, when I did my research, I found they had started to smoke when they came into hospital. And we can't have that. We cannot say that there is any room in our services for an environment that introduces people to smoking, so that patients are admitted as non-smokers and there is a rite of passage to leave as a 20-a-day smoker. Those days are gone, and thankfully I think this new CQC guidance helps us to not be afraid anymore, but to be really ambitious for our patients and to make sure that we're not going to introduce them into that kind of environment where smoking is the norm, and we're not going to leave them struggling with this treatable illness. We're going to really be assertively treating this illness in an environment where they can succeed. Next slide, please. Now, the impact of smoking and the toll that it takes on people with mental health problems is colossal. If I had serious mental illness, I'd be dead by now. And I don't want to be dead. And I don't want people and women like me with serious mental illness to be dead either. They deserve better than that. People with mental health problems suffer a toll of debilitating and painful physical health problems. And you don't need me to tell you about this: heart disease, lung disease, 15 different types of cancer, osteoporosis, terrible problems with gum disease, tooth loss, and pain from all of that. And the results there is very clear to see that if you're a smoker with serious mental illness, you're going to die around the age of 54. And if you're a woman, you'll be dead by the age of 57, typically. And we can prevent that because tobacco dependence is a preventable illness. We must not condone national health services where people are developing this preventable illness and causing suffering to themselves, to their families, to their community, and a heavy burden on the NHS. Next slide, please. Now, we've all been very well informed about the physical health problems that are caused by smoking, but we're less well informed about the mental health consequences of smoking. So I thought I'd just say a few words about that, because I think it's particularly relevant for us that we pay attention to it. It's often the case that in mental health trusts, we badge smoking or tobacco dependence as a physical health issue. It is absolutely not a physical health issue. It causes a toll of physical health problems, but it also equally causes a toll of mental health problems. It causes higher rates of depression, anxiety, panic attacks, and stress. It causes more severe symptoms of psychosis. Consequently, it causes people to have longer time in hospital and more frequent admissions to hospital. In many cases, it is the direct cause of people having double the amount of medication that they take. It increases the risk of psychosis, bipolar disorder, depression, and dementia. And it increases the age at which you get some of these illnesses. But most of all, it causes our patients to have terrible exploitation and stigma. And it traps people in poverty. From our research, we found that our patients were spending up to 1/3 of their disposable income on their cigarettes. And really, if that is your situation and that is your life, you have very poor quality of life, and there's very little chance of a meaningful recovery. So it's time for us to be brave and to hold our hands up and recognize the fact that we must put tobacco dependence at the front and the center of every single day's work in our mental health hospitals, so we can really transform the lives of our patients. Next slide, please, Elliot. Well, I think I've said enough about this. I think that, people like me have served to help people to develop preventable disease, and to die young. So we must do better than that going forward. Next slide, please. So in the past, it's not just us as mental health providers that haven't been doing very well in this domain. CQC inspectors have been criticising hospitals where their efforts to help people stop smoking was called a restrictive practice. CQC inspectors have also been instructing services to install storage facilities, and this is very unhelpful because it undermines any efforts to be completely smoke-free. And also in the past, CQC inspectors have given outstanding ratings to mental health trusts where the staff have been storing tobacco and escorting patients for smoking breaks. So it's really great to have this new guidance which can help both of us to do better as we go forward. Next slide, please. I want to just say a few words about why people smoke, because I think that really helps us to do better to support people and to make it easier not to smoke. First of all, people smoke because they become dependent on nicotine, and then they need to keep topping up that nicotine in their system. And we can help with that if we provide prompt and plentiful and prolonged amounts of nicotine replacement therapy, either in a vape or in a patch or gum or an RT product, or with a nicotine analog medication. They also have this desire or this want to smoke. And the reason for that is that it will alleviate their terrible withdrawal symptoms if they don't keep that level of nicotine topped up. And we can help with this if we educate people about the benefits of stopping smoking. They also develop a positive view of smoking. So they think that if they smoke, it will help them to reduce their stress. And this, of course, is completely untrue. We can really help people to understand the harms of tobacco smoking if we routinely test their carbon monoxide level. And it's so important that we start to do this every day for every smoker in our mental health services, in the same way as we would test blood sugar levels for our diabetic patients. We must be testing carbon monoxide levels for our smoker patients. And finally, people smoke because they get impulses to smoke, and there are cues all around them to smoke. So if they're in an environment where they see dog ends outside the door, that's a cue to smoke. And we can help with that because we can make it easier for them if we take away all those cues to smoke in our smoke-free hospitals. Am I running out of time, John?
Just 2-minute warning now, Mary.
2-minute warning. Okay, I'll speed up. Next slide then, please, Elliot. I just want to say that we now want to have a shared promise. We want to say that as service providers, we will never again think about tobacco dependence as a lifestyle choice or a bad habit or a personal freedom. We'll see it as a powerful addiction, a chronic and a relapsing but a treatable condition, and we now know how to do that, and we're getting better at it all the time. Next slide. And if we thank you, Elliot. So I think the CQC is in a unique position to help to support us with moving in the right direction with our practice, and this new guidance is really important to help to improve these standards of care. And it provides some really good clarity for us about the storage of tobacco, because I think in the past we were nervous about what to do and whether it was going to be considered restrictive practice or not. So this is really helpful for us, and I want to thank CQC for providing that clarity, because it's very similar to the way that we ban plastic bags to reduce the suffocation risk for our self-harm patients, or we confiscate alcohol in order to improve the health and well-being of our patients as well. Next slide, please. And I think Paul has already addressed this, that we are not going to be concerned anymore that having a smoke-free policy would be considered a blanket restriction, and that's really reassuring. So next slide, please. And this is my final slide, John. Hope I haven't gone over time, but I want to finish by saying that, you know, tobacco dependence, it is the leading cause of preventable suffering and premature death. And admission to hospital is a super opportunity for us to identify smokers, to offer them support to stop, and to make sure that they can achieve that with really generous access to the treatments, to nicotine replacement therapy, nicotine analog medications, and also the behavioral support that we can give. But most of all, to create a space that's completely smoke-free, where stopping smoking is the norm and people can have a really good opportunity of recovery. So thank you for listening. Thank you again, John and Elliot, for the opportunity, and look forward to your questions.
Brilliant. Thank you, Mary. That was a tour de force and a really, really great kind of motivating rallying cry, I think, for all of us on the call. Just a reminder, please do put any questions for Mary in the Mary and Paul in the chat. And we'll move swiftly on to our next presenter, who is Elliot Smith, Policy Assistant at ASH, and Elliot facilitates our Mental Health and Smoking Lived Experience group. And so we ran this guidance by our lived experience group, and they've offered some reflections which Elliot is going to feed back to the call. So take it away, Elliot.
Hi, yeah, as John said, I'm Elliot and I convened the lived experience group. So let me just tell you a little bit more about the group before we get into the feedback that they offered on this guidance. So the group is a small group of experts by experience who all have a history of mental ill health and of tobacco smoking. The group members all actually have inpatient mental health experience as well, and they're also people who have done some kind of patient representation or patient feedback in the past, so they're quite used to thinking about kind of the patient experience as a whole and kind of feeding back on that. And this is sort of an ongoing piece of work that we have at ASH to kind of bring lived experience and co-production in. And so, as John said, we decided to run the CQC guidance past them. And we really just asked them to reflect on any issues that kind of came up when they were reading through the guidance that they thought might come up in the implementation of smoke-free policies in wards. So yeah, this is really just an opportunity to hear a patient perspective on the guidance and kind of what they had to say about this. So I'm going to go through a few key themes that came out of the discussion. I think they do reflect quite nicely what Paul and Mary have already been saying today, which is good. It's not an exhaustive list, but just some of the things that we heard. So I think the first thing, and perhaps does go without saying, is the importance of staff really being on board with smoke-free policies. So unfortunately, we did hear feedback of some sort of horror stories of patients even being sort of teased by staff members who are able to leave the ward for breaks and smoke, and also there being a lot of inconsistency in terms of staff buy-in, with some staff being sort of prone to sneaking patients cigarettes or kind of bypassing the smoke-free rules, which they felt could really exacerbate existing tensions on the ward, and sort of this idea of not really knowing the consistency with which the rules were going to be applied being a source of agitation and really quite difficult. And so it was just really clear that consistent buy-in from staff is really important. And, perhaps there is this feeling from staff that they are, calming someone down by giving them access to tobacco, or they're kind of easing the situation. But actually the feedback we heard was from the group was really clear that actually any inconsistency just causes more frustration and more difficulties. The next theme was a focus on long-term health. So the group felt they were really motivated by thinking about their long-term health and focusing on that. So we had people say that they kind of felt sometimes there was an assumption that they were just being kept smoke-free for their time on their ward, and that they'd probably just go back to smoking once they were discharged. But they felt that actually they would have really benefited from feeling a very meaningful attempt to quit, and sort of a real commitment to that as the beginning of a sort of successful quit attempt rather than as a short-term abstinence. And I think they said that, if this smoke-free policy could be explained to them in terms of a wider commitment to their physical health, that would be something that would really motivate them, both in terms of, as Mary said, there's all of those physical health issues that are disproportionately found in this population, but also as a way of sort of feeling like they're taking back a bit of control over their health. This is a great starting point for that. So the takeaway here being is just, how can we frame this policy in terms of a wider effort to help improving health? The next thing that was really clear that came out of our discussion was the need to replace the culture around smoking as well as just removing the tobacco. So they felt that in the past, going back years, that they felt that smoking had provided some real positives to their time in wards, actually, and that it gave them access to garden time or other outdoor breaks, that the smoking often led to one-on-one bonding times, either between patients or even between patients and staff, and the simple you got a lighter or something broke down barriers and kind of enabled them to have some of those social interactions. And they were really clear that really does need replacing on the ward. So let's not just replace the tobacco with vapes, which of course we'll come on to in a bit, but actually replace those social and environmental opportunities that smoking breaks offered, and that would kind of ease this process along a lot. And on this, they really felt that the policy couldn't be separated from ward culture as a whole, and that this was kind of a good moment to think about, are we creating the most therapeutic environments? What can we do to make this a culture that does, really promote people's well-being across the board? So yeah, the takeaway being, let's replace the culture around smoking as well as replacing the tobacco products. And then finally, or maybe the one before last, respecting patient autonomy. I mean, it goes without saying, but I think the idea of restrictive practice has come up a lot. And I think obviously wards will be very concerned about how they can respect and maintain patient autonomy whilst putting in place a restrictive policy. So I think people sort of fed back that when you are being admitted to an inpatient setting, you do feel like you're losing a lot of freedoms and having rules imposed on you that aren't imposed on you in civil society, and that this can be quite frustrating. And obviously having your tobacco taken away is a bit of a paradigm example of that. And they felt that there was a few things that they felt could have been helpful during that moment. So one was that when in the moment that the tobacco was taken away, they felt if they had been handed vaping products or a vape kit, they felt was kind of an equivalent monetary value, that could have really distilled some of the anguish to make it feel more like an exchange than a confiscation, especially if people have spent quite a lot of money on those tobacco products. Like 2 packs of cigarettes could be 40 quid, and that's a lot of money to people, and feeling that they were being given something in return and not just having those removed, they said that could really ease that moment. And then also clear communication around this, why are wards doing this, why is this important, making sure you really bring patients along on that journey. And then also they felt that it would be useful to know at that point of admission who on the ward would be the best person to follow up with if they had more questions about the policy or wanted more support on going smoke free. So of course the incentive to be treat patients with respect and dignity. And finally, the incentivizing alternatives. So we heard that having a range of vapes available, so different nicotine strengths and different flavors, so that patients could choose a product that worked for them, was important, and also having these consistently available. I mean, we heard one patient said that she was being told to order vaping products using delivery services, which of course shouldn't be happening. As Mary said, we really want to treat access to vapes like we would treat access to other medications to treat issues. And this includes extending this into the community. So do you have a clear plan for how patients are going to access vapes when they're discharged so that they don't just fall back into smoking? And they also just said, is there other ways that you can incentivize people to go smoke free, even even though you have got the rule in place? There's no reason why you can't treat it like you are trying to persuade people. Can you incorporate some kind of incentive scheme into the CO2 monitoring? Someone raised that they had in the past had like weigh-ins and there'd been incentives around that in the ward. Could you do something similar with vaping and CO2 monitoring? So I think the takeaway being, yes, you are not giving people the option, but maybe think about how you could persuade them if this was optional, so that you really are creating a service that is not going to feel frustrating and restrictive, but actually something that people are quite happy to participate in. So that's a whistle-stop tour through that. Thank you. If you have any questions, please let me know. If you'd like any further details on anything I've discussed today, I have a much bigger document of feedback. So if you would like any more detail, do get in touch. Or if you want more information on the lived experience group, I'm happy to talk about that too. So I will leave it there and leave some time for Q&A. Thank you.
Brilliant. Thank you, Elliot. Some really, really powerful reflections there. And I think some really kind of a bit of a challenge for service as well, with some of those reflections about how to kind of implement smoke-free policies in a kind of the most effective way, whilst also respecting patient autonomy as well. So if everyone all the speakers want to turn on their cameras for the Q&A, we've got some really good questions, and I can see people are having a good discussion in the chat as well. And so the first question is one, I think this one's probably for you, Paul. Someone just asking for clarification on the blanket restriction form, just clarifying that they don't need to worry about recording smoke-free policies as a blanket restriction. Oh, you're on mute.
Sorry, it's a really good question, but from where we're coming from, it's that you need a policy in place, and that policy in place then guides people. And from there, you need that consistent approach across approach around implementation of that. And inpatients should be smoke-free. So they should be smoke-free, as we understand. And so with that, I wouldn't say you have to record it. What we have to be really clear about is that we don't recommend smoking. We understand all the issues around that. We understand that why do people smoke? If you wrap everything around a service that's right, that you've got the right staff who understand the policy, understand the guidance, who support people, the people who actually live in those services have a say in what they do, that they understand that if they want to not smoke, that they have enough activities in place so people don't get bored. They ensure that when they go out on Section 17 leave, it's not about smoking, it's around moving forward. And it's that consistency, I think, that lets people down. Whether we record it or not isn't the issue. There's a much bigger issue here. It's around giving people activity. It's when people go into hospital there for the shortest period of time. Can I say that we have this, and we've had a lot of providers asking us around similar blanket restrictions in terms of, say, takeaway food. And we know the issues around takeaway food, increase in weight, diabetes, and those. And we say the same things. Just get a right policy that staff can follow, that you've got senior leaders who can actually role model and work with people, and people have a say in moving this forward. I know there's been some talk around like the confiscation and the destruction of material and about tobacco. And I know people get very, very passionate about this, but from the off, when people come in or admitted, it's those honest conversations that we would expect, that people have a right to have a say about what they want to do, that they have a right to actually say, this is what we want to do with our property. I think that's really important. Now, during the process of admission, if people get the advice and they decide, well, actually, I'm stopping smoking, I'm going on to vapes, and I'm moving the community, where there's a policy that you store, well, actually have that conversation. Do you want to keep that, or do you want us to destroy it? You know, it's moving forward where the person has a say.
Great. Thanks, Paul. I don't know if you had anything to add, Mary?
Particularly, I think what Paul's saying is really sensible, that it was also echoed by Elliot coming through loud and clear from the service users. Where there's consistency, good communication, things go smoothly. And people who smoke, they really, really, really want to stop, and we need to do everything we can to help them to stop. And so all of those things together, it's not just about giving people vapes, putting that in their hand. It's about all the other things. Helping them to find meaningful alternative things to do is equally as important as giving someone a vape. So everything together. Let's see if there are any more questions before we run out of time.
Yeah. So there's one actually, which is a bit of a challenging one for services, which is how do we break this smoking culture on the wards when some doctors and staff are smokers and don't prioritise smoking cessation? So Mary, that one's for you, I guess.
Absolutely, sure. I mean, I think it's all about education, because we all need that. I was like those doctors and nurses 10 years ago, before I learned what I know now. And so I don't criticize those doctors or nurses or staff who have that attitude. I want to have a conversation with them. I want to help them to see things the way I do now. I haven't always felt like I do now, which is, really ambitious to make sure that every smoker stops as soon as possible and for good. And so we want everyone to get onto the same page, but it's a journey. We can help people by not criticizing their opinion, but by showing them and helping them to see things the way we do, and showing them what a wonderful thing it is, what a joy it is to help someone to stop smoking and see their life just be completely transformed. It's fantastic. I think we need to make sure that our services are offered across the care pathway, and we heard that coming through from Elliot's comments that were so brilliant from our service users, saying we don't just want a ban on smoking in hospitals. We want tobacco dependence treatment right across the care pathway, not just when we're in hospital. But also we must have tobacco dependence treatment for our colleagues, for our staff. When I started to become interested in smoking, the rate of smoking amongst mental health staff was very high. It was 24% in the trust where I was working. Thankfully, it's now down to about 8%. And that's because in our organisation where I was working, we helped the staff to stop smoking as well. And credit to my colleagues who are part of that. It's really important that we have sympathy for all smokers. It doesn't matter if you're the chief executive or what role you play in the organisation. If you're a smoker, you need help and you need support.
Brilliant. Thanks, Mary. I think that's a really good note to end on, actually, a really positive note. Thank you, everyone, for joining today's session, for your questions. I know we didn't get to them all, but there's a wealth of information in the slides and discussion for us to refer back to. And obviously, special thanks to Paul, Mary and Elliot for your brilliant presentations.